There are several things that struck me on the visits, but probably the overarching theme is the recognition that things have to change rather dramatically, and they have to change so that the results of the change lead to better outcomes, better safety, better service. They're particularly focused on the service and outcome pieces, as I could tell, but all three were discussed. And with the desire to get lower costs, to have lower spending. And the other thing that struck me from all three visits, and it struck me perhaps because of the types of people who were in the room, but they all recognized the need that they're going to have to work together somehow. And the kinds of people I'm talking about, these were general practitioners, there were some specialists, there were people who ran the hospitals. There were people who were in what I call the payer side or the commissioning side, but the government payer folks were in the room. And there were some nurses in the room. And all of them really felt that they needed to change and work together somehow. Then the second big observation was it wasn't exactly clear how they were going to do that. And the current legislation and mandates that are occurring are still not clear. And indeed, the risk could be that as those mandates become clear on what they should do, that might interfere with their ability to work together. And there was a fear of that. I could see there was a little confusion, not sure exactly how to come together. And then the final point was they were debating a fair bit about the idea of incentives and how do we really make this work. But the overarching desire to work together was really clear in all three places. And even those folks that might have been a little more reluctant realize they're going to have to at some point. And the sooner the better, actually, from the standpoint of the National Health Service. They have several barriers that they face. One would be, is there, and this is a question for ministers and everybody in this country, is there truly a desire for higher value care, better outcomes, better safety, better service, and lower cost over time? Or is there more a desire to just have lower cost over time? Now that may sound like a subtle difference, but it makes a difference on how to engage the people who are going to make the changes. Professionals, as all of these people really are, the people in administration, the people in healthcare delivery and nurses, the hospitalists, general practitioners, they're really all professionals. And to the extent that their professional desires of really performing well and getting good results is ignored, and all they are asked to do are get the costs out, there will be much harder time to rally them around to work together. They're just, because then you'll degenerate into just saying, what are the incentives and how do we pay people to do this, that, and the other thing, when really the key incentive that will drive true professionals is really based on respect, giving them the authority and the ability to improve the outcomes and measure the outcomes so they can feel good about that. And in my experience, that will trump everything. It's not the money that does it. You can always have a little incentive built in here or there. There's no question. But you can have the largest incentives if you treat people as though they are not professionals and they don't have the ability to do what they would like to do to improve the outcomes that somebody else is measuring. They're not going to respond to those big incentives. They will, if you put money over there, they're going to go after the money. Wherever it goes is where the money is going to attract people. On the other hand, if you really raise this idea of higher value care and you ask the professionals how to do it, they'll do it. Everybody I met have great ideas and they can see how to do it. But if they have to follow too many regulations and too many restrictions and they are precluded from doing some right things, such as reducing the sizes of hospitals, changing where patients are seen, not in emergency rooms, for instance, reducing length of stay, getting patients into more appropriate environments for their care. If they're restricted from being able to do that, it will be a very difficult challenge for them to change very much of anything. They'll just keep doing, well, we'll keep doing what we're doing. The core of the idea is a good one. And it basically is saying, let's have somebody who has experience and knowledge and wisdom with regard to healthcare delivery be responsible for how the dollars are used. But I have several observations on it. First, it's not all the dollars. They don't have the control of the dollars that the hospitals may end up saving if the GPs are successful in their money. And my viewpoint, all the money should be in one pot, because you have a single system in the country, and if you really do, all the money ought to be in one pot. Now, how you distribute that is a little different, but right now they've chosen to have the GPs, I think, handle roughly, 70% of the budget or something like that. Now, what that basically means is GPs collectively are now being asked to be the payer. That would be our language in the United States, the group that pays the money. I think in yours it's commissioning. In the United States, that would be putting the GPs in the position of becoming the insurance company, which means GPs then will have to negotiate on prices. They will have to sit down and try to get hospitals to cooperate. They'll have to try to get the specialists to cooperate. They'll have to try to negotiate prices on how much they will get paid, which will accomplish many things. One, it will immediately take a gap between GPs and specialists that already exists and potentially widen it to an adversarial situation when, in my view, what you need right now is bringing them together, not separating them. So there's an opportunity for that to happen. The second is that if they are able to function the way I've read it in the documents, it sounds like they're going to also be asked to be a gatekeeper, which means decide where patients should go and maybe even what doctors they should see, which may make sense, but other parts of the paper say that patients can choose where they want to go, which you can't talk out of both sides of your mouth here. You can't do it both ways. So if you did do something that the GP was truly a gatekeeper, we've lived through that in the United States. And what has happened when GPs are gatekeepers is that if a patient is denied going to a specialist when the patient thinks they want to, the patients will start beginning to feel that the gatekeeper is rationing care. Even though they don't need to see the specialist, people will begin to feel like that, especially if they know the GP is trying to manage the money, not just look out for their welfare. The second thing that can happen is if they do go to the GP, to a specialist, but it's not the specialist that they really want to see, or the specialist says, well, you need these 4 things, and the GP says, no, I'm only going to approve 1 or 2 of them, then the next thing that can happen is the specialist and the patient will talk about that. And they'll say, this is outrageous. Your gatekeeper is denying these things. This is exactly what happened in the US. And you end up having the specialist or the hospital being able to stimulate the patient to be even madder at the GP. That will put political pressure. That's number one. But the worst thing it will do, it will destroy trust between the GP and the patient at the time that you need it the most in this environment. So I understand the philosophy of controlling the money, but we have lived through experiences like this. And anytime you put the money into the hands of the physicians like that, in just one group, you can set up barriers here. So to me, if we are going to distribute the money out to organizations, which I strongly favor, I like the idea of capitation and money going into a single pot, let the providers deal with it. You need to have providers that are working together, not adversarial. They're really closely linked together. So again, in all my visits here and the 3 different places I saw, you're really close. You're really, really close. And the people that I've seen want to come together. And it's how do you allow that to happen? That's the key challenge that the legislature will have, or your parliament will have, and your ministers will have, is how can they create an environment that will allow that to flourish? And they do not have to do it with a standard rubber stamp set of ways of doing anything. That's a catastrophe. But you do need to have a standard set of expectations. Outcome safety service, lower costs. And let the systems vibrate. Let them do what they need to do for those patients. And those places that get the better outcomes are the winners, should be the winners.